Today I'm going to really piggyback off of what Dr. Oaks so eloquently summarized about dealing with dementia. And in particular, we're going to talk about dementia with our veteran population. And so today I'm just going to go through kind of how the VA is approaching dementia care, evaluation and differential diagnosis, which is kind of a shortened version or kind of reiterating some of the things that Dr. Oaks talked about. Agitation and behavioral problems. So really, what are these behavioral problems that we're seeing in our populations? How do we assess for this, and how do we intervene? And then I'm going to kind of conclude with some veteran-specific considerations. So really, in a lot of ways, a lot of the things we're going to talk about today can be used across many different populations, but we want to make sure that we include assessment of the individual. So, the aging VA population, we kind of talked about this a little bit, but they're greater than 40 million Americans over 65 years of age. And 9 million of those individuals are veterans. So that's actually a significant proportion of the population that we see here at the VA. And 52% of veterans receiving care in the VA healthcare system in 2009 were greater than 65 years of age. So that means that we're providing over half of our services to older adults at this time. So with kind of the dementia prevalence we talked about before, we know that that many people, as we see this increase in aging, we see this increase across the world in all industrialized nations. We see that the aging population is actually growing at higher rates than we've ever seen before, and that these people have not only chronic illnesses, but are developing illnesses, or developing dementia disorders. Nearly 50% of those, again, over the age of 85, are in some stage of dementia of Alzheimer's type. So really, that's specific to Alzheimer's disease, and it's not even necessarily considering some of the other dementias that we treat as well in those populations. So obviously, dementia of the Alzheimer's type is the most well known, but again, other dementia subtypes constitute about 25 to 30% of all of the cases. So again, dementia is often undiagnosed or underdiagnosed in the primary care setting. Greater than 1 in 7 of those with dementia of Alzheimer's type actually live alone and without a known caregiver. And that's actually a huge problem and issue because, as you will know, our caregivers are our main source of information a lot of times, because with a lot of dementia patients, they're actually unaware of the severity of their deficits. And right now, dementia with Alzheimer's type is the 6th leading cause of death, which those rates are going to increase dramatically. So what is the VA doing about this? So as far as the VA Dementia Initiative in 2006, VACO, which is our national organization, national governing body in some ways, I think, they actually established a National Dementia Steering Committee. And with this, they created 3 work groups to address multiple areas. So clinical care, coordination of care, and administrative issues. And with that, they came up with a total of 64 recommendations to enhance VA's dementia care. Specifically, there are 39 of these that actually speak to clinical care. So that means that there are a lot of things to be done, a lot of ways that we need to learn to intervene for our patients. And so with that, they have developed interdisciplinary teams at the visit and local dementia committees to really address this issue in each specific region. So some of the highlights of those recommendations are that there's a need for provider education, which hopefully that's some of what we're doing today and what we do in the VA system. to prepare for this increase of veterans with dementia. And we want to focus on the importance of comprehensive dementia evaluation and treatment. So again, kind of going through, not only are we going to deal with one thing, but we're going to deal with everything kind of overarchingly. So what does that look like? And again, we kind of talked about some of these things before. So I'll go through these things quickly just to touch on them. But we want to do comprehensive dementia evaluation. So what does that look like? Well, there's medical evaluation, which includes neurological and physical examination, reversible dementia panel, medication review. Dr. Oakes talked about how important those aspects are. And then we really want to also make sure we put a heightened importance on the clinical interview, and that we need collateral information. We want a caregiver, an adult child, somebody who is able to provide us with information about that person's functioning, about what things they've noticed, the changes they've seen. We need that in order to really get good baselines, because a lot of times our patients are not reliable sources. So we also want to address, of course, the functional, cognitive, and behavioral decline, look at physical and behavioral signs and symptoms, as well as functional limitations and strengths that the person has. So we also want to make sure we're not only asking about things that a person can't do, but we want to make sure that we understand how a person is actually functioning. There are certain things sometimes when we look at ADLs or other things that people may have never done. I know many veterans may have never done their laundry or cooked their meals or washed the dishes because their wife did that for them. And so we don't want to ask somebody, well, are you able to do these things if they never were able to do them in the first place or never had to do them. So we want to make sure we address those things individually. And then neuropsychological testing. So really going through and getting information on all cognitive domains, because as we've talked about, there are numerous types of dementing processes, and a lot of times, especially when we're trying to diagnose things earlier, a lot of times we're able to really get that differential when we're able to address some of the things early on. So in going through some of these things, again, we've talked about some potential reversible causes. One is that is depression. Again, a lot of, especially in our veteran population, we have a really high level of comorbidity of mental health issues, and depression is one of them. But one of the things you want to consider is that it is very rare for the first episode of depression to have an onset after age 60. So usually patients who have not ever been depressed in their life don't all of a sudden become depressed. So you want to look for that shorter duration, more abrupt onset. Those are the types of things that you'll see if a patient is depressed versus demented. You want to consider depression from a mood standpoint versus apathy, because a lot of times apathy is actually a symptom of a dementia process, whereas for our patients who are depressed, they may look depressed or be perceived as depressed because of apathy, but really it can be a down mood. So really kind of teasing those things apart. And then also understanding that when we're doing testing or looking at the cognitive processes that our patients have, we notice that patients who are depressed have slow processing speed, decreased retrieval, decreased problem solving, impaired working memory. They have encoding versus retrieval deficits. So a lot of times they haven't gotten the information in properly, but they actually would have been able to retrieve that information, which is actually the opposite of what would happen in Alzheimer's disease. And it rarely leads to focal deficit. So for instance, an aphasia. So usually patients wouldn't have these specific issues. And then the cognitive complaints often exceed the demonstrated deficits on testing or other things. Again, we're going to see the patient complaining more about having problems than actually the deficits they have if it's depression versus dementia. So again, for some patients, you'll treat the depression and you're going to monitor them from other types of cognitive problems. Delirium, again, is another one. We want to make sure that we look at the onset of the symptoms, if it's abrupt versus insidious, meaning that any abrupt cognitive changes, if mom was okay or your dad was okay last weekend and then all of a sudden you notice these changes, and it most likely is in a dementia process. And so also that delirium has a high level of co-occurrence with dementia. Dementia is probably #1 risk factor for a delirium. Fluctuating mental status and impaired consciousness and attention are kind of hallmarks of a delirium. It may be hyper or hypoactive delirium or mixed, and often caused by confluence of predisposing or precipitating factors, usually that being like illness. Again, some of these we've already gone through, but intoxication, metabolic abnormalities, infections, vitamin and nutritional deficits, CNS insult, we talked about some of those, toxin levels, sensory impairment, and also pain. Another thing is that we'll talk about some of the cohort differences, but you would be very surprised that a number of patients who are in chronic or severe pain actually demonstrate cognitive decline and what appear to be cognitive issues. A lot of times that's because of an intentional problem, because of the level of pain that they're dealing with. So that's also something that we want to make sure we assess. Acute or chronic medical problems. So again, there are a plethora of different things that we see, and here, especially in the VA system, our patients have a lot of comorbidities. So I cannot tell you the number of patients that we have who have COPD and patients who have CHF, and so you just go down the list, and those things can also impair cognitive function for a variety of reasons. So we want to make sure that we look into all of those things as possible factors. And here is what we would consider a reversible dementia panel. Obviously, the first are kind of the tests that we would give. Especially in the VA population, you also really want to make sure that we test our patients for, and older adults in general across the spectrum, we want to make sure that we're testing them for STDs. HIV is coming upon us as an issue, especially HIV-related dementia. Actually, that's the largest growing segment of the population who is actually going to have AIDS, just because the medical care has improved for patients, and now we're going to see some patients who have had HIV who are going to enter into older adulthood. So we need to make sure we're understanding and seeing those things. And also the rates of STDs in our older adult population is high. So we have still seen things like neurosyphilis. So you want to make sure that you're able to look into those things and consider them when you're treating. Dr. Oakes talked about neuroimaging again, just to look through things and make sure that you're looking for that kind of known atrophy that's not normal, but that is kind of highlights some of the dementias that we know have known that we have research on and know cause atrophy, such as dementia of Alzheimer's type, Lewy body, and some of the frontal temporal dementias. Polypharmacy, again, medication issues. We cannot stress enough how many patients can have some type of cognitive impairment that is directly or indirectly caused by their medication. And it can be caused by the medication just itself, or it can be caused by mismanagement a lot of times. So we really want to make sure that we look at that we know, and that we are paying certain attention to contraindications for older adults. So some of the things at the bottom, and I really urge people and trainees and everyone else to really pay attention to the Beers criteria, which was actually updated recently, and we want to make sure that we're just very aware of the effects that medication can have on our older patients. And so neuropsychological evaluation. So again, we want to make sure we're looking at all domains of function. And we tend to highlight memory because memory and kind of the amnestic portion of memory problems seems to be the hallmark of Alzheimer's disease, but in actuality, we see that there have to be cognitive deficits in other areas, or really that's just cognitive, an MCI within an amnestic type MCI. So we really want to make sure that we're looking at each one of these cognitive areas to see what are the specific issues that are going on with the patient, what's happening at certain times, and how can we help them to function better. Because in a lot of ways, if we know the types of problems and impairments they have, we can actually work to supplement their functioning in their current environment for a longer amount of time. So we want to make sure we're looking at all of these things. Again, differential diagnosis, and I'm going to go through these quickly because it kind of just reiterates again what Dr. Oakes spoke about. Again, that JT is the most common. Vascular disease is vascular dementia is kind of the second most common, and actually one of a number of our veterans have so many vascular risk factors that I would say in our population, vascular dementia, we see much higher proportions of that than the general population. So that's something that we definitely have to consider. And then again, kind of the classifications and how these things kind of line up in overall treatment. So again, we want to make sure we're looking at, is it a reversible cause or a non-reversible? Is it a cortical, subcortical, or does the patient have a mixed profile? We have seen a number of patients who have a vascular dementia and have some Alzheimer's type symptomatology, which is quite possible. Is it a primary or a secondary, meaning somebody has Parkinson's disease like we talked about before, or if somebody has HIV, one of the things that we do know is that they likely or they can develop a dementing process due to those disorders. And is it progressive or not progressive? So here are kind of a list of the major non-reversible dementia syndromes. And it's really important to note that assessment and evaluation is key to intervention across settings. So again, we just talked about diagnosis, but why is that so important? It's so important because baseline function is really the vital component to really understanding your patient and our resident, in our case here. We must understand what their functioning was prior in order to tell if there's any change or to even initiate change in their behavior. Again, collateral sources are vital in providing that information, and therefore they should be included in the diagnostic evaluation as well as treatment planning. So we need to really understand what the veteran's situation is, what their living situation, environmental factors, all of those things are in order to move forward with any type of treatment planning, and even in order to make a really good diagnostic profile for that patient. So my first question is, well, what is agitation? A lot of times I see charts and it just says that the veteran was agitated. So I'm on the palliative consult team and I work in our community living center, which is kind of equivalent to a nursing home type of environment. And so I will see nursing chart that the patient, or in our case, veteran, was agitated. So what does that mean? Anybody? Nobody knows what agitation is?
It's probably a conglomerate of things.
So it's a conglomeration. So how is that helpful? I mean, if we were to say in the chart, oh, the patient has pain, and we just kind of left it there, how is that helpful is really the question. So what we really have to do is we really have to learn how to assess behavioral problems in our patient. We cannot chart that a patient was agitated because nobody in this room can give me a standard answer as to what agitation is. It can be so many different things, and so how are we going to treat that thing that we can't define? And so that's one of the things that we're going to talk about today, is really getting at what the behavior is. So agitation is a term that is often used to describe behavioral symptoms that include verbal aggression, physical aggression, purposeless behaviors, and resistance to care. So again, verbal aggression, yelling out, cursing, those types of things, physical aggression, hitting, kicking, purposeless behaviors, scratching, rocking, wandering, those types of things, and resistance to care. So refusal to care, refusal to take medications, refusal to eat, and other things where a patient doesn't want to participate. Even things like personal hygiene would be considered in those areas. So again, these are very large groups that people tend to say that the patient was agitated, but they are very different behaviors. So we really have to look at, well, what's really going on. So symptoms. So all of the behaviors are actually thought to be symptoms of the disease or disorder. Therefore, there's likely an underlying cause or a trigger to the behavior. In these situations, what we do know is that for dementing processes, our patients have a disorder that has affected their brain and they no longer are lacking cognitive function. So we don't expect all of a sudden for them to be able to remember everything. And so again, that goes with function, that goes with behavior, that goes with social comportment. We can't just assume that those things should remain intact for somebody whose brain is actually failing. So we want to make sure that we consider the behavioral problems as symptoms like we do many of the other cognitive issues that our patients have. So how do we assess and treat these things? So the first is to know the likely causes. So it's important to understand that behavioral symptoms occur over the course of the disease process and often increase in the later stages. Again, this isn't always true in that we have some patients with FTD, for instance, so the frontal temporal dementia, where actually some of the very first symptoms are people who begin to lack appropriate behavior, and that's because we know that some of the areas that are affected primarily in the beginning are actually the frontal lobes that have our executive functioning, and so our ability to inhibit and hold back, our ability to plan, our ability, so those patients have lost that, and so a lot of times their first demonstration of issues is that they do things that are very inappropriate. So sexually inappropriate, or verbally, or cursing out of line, those types of things we'll notice with those. But for most, the behavioral difficulties usually come later. And so there are often triggers. The main trigger is actually difficulty communicating. So if we think about it, a lot of times we're dealing with older adults, but we're also dealing with, if you think about how we develop cognitively, we are actually regressing cognitively and functionally. So our ability to communicate, so our verbal and language skills are declining. And then, so with that, it's kind of the same thing that we see when we think about children and how they develop their abilities to communicate. And so when those abilities kind of decline, we start to see regression. We start to see people who act out as opposed to being able to put a finger on exactly what they want. So if I can't communicate to you that I'm in pain, or if I can't communicate to you that I'm upset or that I'm sad or that something is scaring me, instead, like we see kids who have a temper tantrum, or who have a fit, or who start to get upset, or who shut down, we'll see the same thing with some of our patients. So really, communication difficulties can be a primary source of issues. Environmental conditions. Thinking about the world kind of around you and not being able to make changes. If you are not able to remember where you are, and you feel lost, or you don't know what happened, financially you see the money isn't there that you thought was there, or you weren't able to have control over this situation, what you start to see paranoia, you start to see people who are fearful and who don't know where they are. So those things also can trigger different behavior outbursts. And then physical discomfort. So we talked about pain, and we talk about even if somebody is hot or cold, thinking about some of the functional limitations that our veterans have and the inability to really have control over those things anymore can really trigger other behavioral manifestations of problems. So one thing I thought was very helpful is that I found a mnemonic that is used for an observer-based approach to really assessing behavior. And so that mnemonic is "it's over." And so we're going to go through each one of those things and kind of give you an outline of how do we assess this, how do we put something more than just agitation in a chart. And so the first thing is to identify. So what is the problem behavior? It's very important to use a more specific term, like I said, than agitation or difficult, because we really want to identify the source of that behavior. So again, we know that a lot of times these behaviors are being triggered by something. And so in order to really understand that, then we have to really determine what's going on in their environment. And so we really want to be able to pinpoint and identify specifically what's going on with the behaviors. The next is T for timing. So when does the behavior occur? What is the frequency of the behavior? So is the behavior a one-time event? Has Mr. So-and-so never done this before? Does this occur weekly, daily? Is it in the morning, the afternoon, the evening, overnight? All of these things can be important because they can actually be related to medication dosing. They can be related to sleep-wake cycles. Especially important when we talk about Lewy body dementia. Those patients tend to have their visual hallucinations and things at night. Has a lot to do with their sleep-wake cycle disturbance, which happens during that process. So we want to make sure that we understand when these things are happening, so again, we understand how to intervene for that particular patient. The next is surroundings. So where does this happen? Does it happen in the patient's room? Does it happen when they come out of the room? We're assessing behavioral problems in the home. Does it happen at home? Does it happen when they try to go to the doctor's office? Do they get really scared in the car? You know, we want to make sure we understand where these problems are occurring, so we can assess what's going on in the environment. Is there loud noise? Are there difficulties with lighting? Those types of things. Has there been a change recently? So we also know that, so our community living center is attached to our main hospital. We will have patients who are moved down to our CLC, then they start to have other problems. A lot of times what you see is that environmental changes, being unfamiliar with their surroundings, can actually cause patients to have a lot of behavioral disturbance. And so they have to, again, get used to what's going on because they don't necessarily know what's going on or can't remember where they are or why they're there. So we have to make sure that we take into consideration any type of environmental change, whether it be a roommate change, whether it be a move from home to an inpatient facility. That is a huge change for a lot of our patients, not only veterans, but for a lot of people. It is actually known that when you take somebody out of their home and you put them into a facility, so a nursing home or someplace else, they actually have a functional decline. And that is primarily due to the fact that they are no longer familiar with their surroundings. And so we really need to be aware of those things and understand that that can actually trigger some problematic behaviors. Overstimulation can also be an issue. And again, temperature change. So it's very hot in Texas, but we can also have air conditioning blowing straight on people, or we have other issues. So we just want to make sure it seems like little things, but again, when you're not able to communicate those things very clearly to others, a lot of times it becomes an issue that needs to be addressed. The next are others involved. So who else is involved in the care? Are there certain staff members? Does the patient respond to a certain nurse, doctor, other staff member in a certain way? Does the behavior problem happen with only unfamiliar staff, or does it happen when the family is present? We can have situations a lot of times where family being present is actually a very good thing. For a wife who comes at a certain time of day can be very comforting. But we can also have the opposite. We can also have family members who are very upsetting to our patients. And that can actually be hard for a family member to understand. But again, it can be even when that family member leaves, that's the upsetting process for the patient because they don't understand what they have to say. So we want to make sure that we look at who all is involved with these problems. Is it a roommate in a residential facility? Is it the fact that a caregiver is overwhelmed at home, or whoever the home health aide is, or somebody else who's coming in? Does the patient respond better to one person than another? It can often be tone of voice. A lot of times our veterans respond better to male voices as opposed to female voices when they're hard of hearing. We want to make sure that we're just aware of who's involved in the care and what kind of role those things can play. D is for very troubling. So how dangerous is it? And this is really important because we really want to address extreme behaviors immediately so that they can be handled. We don't want anybody to get hurt, and we don't want the veteran in our case or a patient in other cases to actually get hurt. So again, there are times and situations where if a patient is in danger of harming themselves, that we do have to take more extreme measures. But if the patient isn't going to hurt themselves, or we can put them in a situation where they wouldn't. So one good example is wandering, for instance. And a lot of places now have wandering gardens, or a place where we can actually have a patient go where they will be safe to wander. Because the wandering behavior in and of itself isn't dangerous. The danger is if the patient is not supervised, or if they get outside of the facility. But the actual behavior itself is not problematic. But in other times, we may have to take more extreme measures. So we really do have to assess how troubling the behavior is. And E is for evaluation. So what else might be causing the behavior? So again, going back to what we did when we wanted to do the complete assessment, again, we want to look at some of those same factors. We want to evaluate the patient physically, and we want to sometimes reevaluate cognitive status. Because again, a dementia is actually one of the leading risk factors for delirium. So a lot of times our patients who have a dementia are more susceptible to that. And so that behavioral problem can actually be the first sign of a more significant medical problem. So before the patient has a fever, before the patient starts exhibiting some of these other problems, you may actually see them demonstrate some problematic behaviors. So again, we want to make sure that we're looking at those things. Medications, again, sensory deprivation. Lots of patients have hearing problems and vision problems. Sometimes their hearing aids are out of batteries, they don't have a pocket talker, their glasses aren't at bedside. Again, if they're not able to communicate, there could be a simple fix to the fact that the patient cannot hear you, and that in and of itself could be a reason for this act up. And recommendations. So how do I respond? So after the previous questions are answered and the necessary evaluations are performed, then therapeutics recommendations can be made and implemented. And again, we think, oh, well, are there specific things that we're supposed to do for a patient? But the biggest thing is that we must know the patient, we must know the situation, and do a thorough evaluation of what's going on. And that's going to set us up for actually being able to engage for problematic behavior much better than anything else we can do or any standard practice. So, non-pharmacological interventions. Why are we talking about these? Why is it important? Can't we just give them some Haldol? Well, we could, but the thing is that Haldol isn't necessarily going to treat that behavior. And so we know that whenever anybody comes and does an evaluation for long-term care facilities, and even our inpatient facility, they are looking to see and will note if we have actually tried a non-pharmacological intervention as our first line for problematic behaviors. And so it is now an expectation, not something that they wish for. So your facilities, no matter if you're inside the VA or out, will be looking for those things because that's what we have to do. And that is primarily because there are no FDA-approved medications for the management of behavioral symptoms in dementia patients. I wish there were. I wish there were things. I wish, again, we had that magical pill, but we don't. And really, it's the same reason that we don't have a cure for the disease, and what's happening is that our patients are essentially losing brain function. Their brain is failing. So we talk about heart failure, we talk about liver failure, but what's happening is that these patients are going through brain failure. And so what controls our behavior? We control that with our brain. So again, we have to consider it in that way. So the next is kind of the 4S approach to, well, how do we do this? How do we come up with these things? And so the first is safety. So we want to make sure we control the risk. So we want to control the risk for our patients. We want to control the physical risk. We want to control the financial risk. So driving is one. So for example, we want to make sure that we limit different things that can happen. We all have seen driving on the highway, kind of the senior alerts in Texas. We want to prevent those problems as opposed to having to deal with them on the backside. We want to prevent falls. We want to prevent really disastrous financial decision making and poor financial planning that can occur. We want to prevent impulsive behaviors. I don't know how many stories we've heard about people who have played all of the lottery, everything for Publishers Clearinghouse, all of these things where people are giving their money away because they no longer have the cognitive function and the judgment to be able to do those things. So not only physical safety, but we want to help with all of these other aspects in care. The next is serenity. We want to manage affect. So we want to know our patients well enough to really avoid overt frustration and anger. Again, a lot of times our patients with dementia do not have good self-control, inhibition, ability to manage their emotions. So if we can keep them in an environment that is much more pleasant and effectively pleasing, then a lot of times we can eliminate some of the problematic behaviors. One of the big things that I tell people is every time I enter a room, if I know a patient is demented especially, I have a smile on my face, I speak slowly, and a pleasant, upbeat tone. And what you will notice, especially for those who are probably more mild to moderate stages, and even those who are later, they respond much better to you because they aren't fearful of what you're saying. They feel they will match your tone because they don't know what's going on. So if you go in and you're positive and upbeat and you're paying attention to them and engaging them at a level that they can in a calm manner, then they will many, many times mimic that behavior. They will often kind of go with whatever you're doing. But if you touch them and don't tell them what you're doing, if you start working around them, if they can't hear what you're saying, then again, that fear, not understanding what's going on, yelling at them in a high tone, talking very fast, all those things do not create a serene environment. The next one is structure. So we want to increase organization. So maintaining schedules, facilitate good habits. So again, our patients can't do the structure for themselves anymore. They have lost the ability for planning and organization, which goes along a lot with the frontal lobe and executive functioning that we talk about. So they can't maintain schedules, but another thing that's very good is when you have a memory problem and you don't remember what to do, you do rely heavily on familiarity. And so by maintaining a schedule and facilitating habits, we actually can keep people functional longer. Very important, especially when you're talking to a home caregiver, to really have them try to maintain a schedule with with that and not get off course, because getting off course again can cause some issues. But again, when you're able to maintain a schedule, you're actually able to maintain function much longer. And the next is sanity. So we want to reduce caregiver strain so that within inpatient settings and at home, the amount and the level of care that a lot of dementia patients will need or currently need is very, very high. We talk about it's a 24/7 job. It definitely is, and it's a job where you have to monitor a functioning adult in many cases who is very unaware of what's going on with them. And so you really have a lot, there's a huge burden and a huge risk to all caregivers, whether it's a person who is within a facility or the spouse or adult child or whoever is the caregiver outside. And so we want to make sure that they seek social support, because again, so many of our patients are then at risk for faulty care and management and mismanagement of care. So we start to then see people who have problems with maintaining the level of care they need to provide the veterans in our cases. So how we usually write these things are primarily behavioral management plans. We can do those inpatient, but we also really, it's a trial and error thing overall, in that your best intervention is prevention. So that's why we talk so much about understanding what the triggers are and what the environment is set up as, understanding what your patient or family member's preferences are, because those things will help to prevent the continuation of the behavioral problems. So we want to make sure that we document the specific behavior problems that one patient may have, and especially if they are frequent behaviors. And in that way, we can try to definitely pinpoint those behaviors for specific patients. So that's kind of how we come up with some of the behavioral management plans for patients. And the next thing are actual behavioral interventions, and there are so many different types of things you can do. A lot of them, again, deal with patient preference. For instance, music is very popular with people, but you have some people who never listen to music. You have some people who love TV and want the TV on, but you have some people who never watch TV. So there is no one thing that's going to work. Again, you have to try many, many different things. But first and foremost, you must understand your patient's abilities and their limitations. And I say abilities because we actually want to keep people as functional as possible. So if a patient is continent, you want them to stay and maintain that for as long as possible. If a patient can, write his name, or if he can speak in this way, or if he can do this, you want to maintain those abilities and encourage them for as long as possible. But you also want to know their limitations. If they can't monitor their emotions, then again, you want to make sure that even though they may be functional in a lot of other ways, they can't manage that very well, and so you're going to have to do that for them. So another major thing is redirection and distraction. Patients can get very focused on certain things and how they are and going on, and so you want to distract behaviors. Works especially well with things like sexually inappropriate behavior or touching and things like that. Provide a distraction, redirect, and go back to doing what you need to do is usually the best way to continue on with those things. Again, surround them with familiar objects. Want to keep your speech soft and low. Again, we're dealing with people who are hard of hearing, but if they're in an environment where they feel like they're being threatened or they don't understand what's happening, it's really important that we make sure that we have calm, soothing voices, keep the environment that way, short phrases, and a slower rate of speech. And I cannot tell you how many people go in and speak to patients at their same rate, give them all of this information, when really they have very slow processing speed, and they just are going to take a while not only to process what you're saying, but to give you a response. So give them the chance to actually do that. And then we have a number of other types of therapy that have been, some have mixed research like snoozling therapy, but that's something that's big in the VA now that they're going to try to initiate across a number of different settings. You'd be surprised about how tactile, so soft textures and different things can actually be soothing to patients' physical activity. So again, walking, allowing patients to wander, aromatherapy, and massage, all of those things can really help.
Can you say a little bit more about what snoozling therapy is?
Yeah, so snoozling therapy is, it's kind of an activity-based. You'll see a lot of lights, so like lava lamps, and then you know how for younger children they'll have the lighted balls that make like stars in the room. And so it can be, it's really different sensory stimulation. And they'll have things that are very soft in the room, and they'll have aromatherapy, and all of these things to really work, I think, to stimulate sensory and to help a patient calm down. So, so again, the research on snoozling is kind of mixed, but the VA is starting to implement that. So you have snoozling rooms where you take a patient in for a therapeutic rec therapy is really doing it, and then I think we're going to snoozling carts, where you can actually set up in a patient's room kind of the lights and the tactile and tactile things or whatever, and give them and provide that for them. Again, I think it's just an environmental type of thing that does calming. It helps a lot of children who are autistic and things like that. So important notes, we must learn to overlook benign behaviors, so things that aren't going to be harmful to the patient. Get to know your patient's likes and dislikes. Work smarter, not harder. Do not force a patient to do something. If you come back later, you'd be surprised. You may look familiar, and so they may come back and do those things for you. Again, ignoring benign behaviors. So if you know somebody is sexually inappropriate, redirect and try something else again, or if you know how to redirect that. But again, those things aren't things that you want to medicate a person for. Avoid personalizing hurtful or insensitive comments is a big one, especially for family members and caregivers and other providers. A lot of times these patients do not have filters anymore and just say whatever. So don't take those things personally. Realistic understanding that some problematic behaviors may not be eliminated. Again, the person is experiencing brain failure, and that intervention is individual and it takes trial and error. So we have to figure out what works for certain patients. So the last part of this, again, that was kind of just generally things to understand. But the very last part that I want to go over for probably like the last 5 minutes before questions is really what we should be considering for veterans. And so the main considerations are, is it a combat versus a non-combat veteran? That can really have a lot to do with kind of their understanding and really their experiences in the military. What generation? So there are definitely generational and era differences within the veteran population and how they respond to different things. Injury and service connection versus non-service connection. So a number of our veterans, if they experience some type of injury or physical or medical problem within the military, they have a service connection, and so those things are actually treated within our service versus patients who don't necessarily have that connection. And then trauma, so we talk about PTSD, and then separate from that, but alongside that, we have POWs, so prisoners of war, and really understanding that people have gone through some really traumatic situations, but also psychologically challenging, but also have overcome a lot of other things. So we want to make sure we consider that. Really, in talking about era and generational things, I think about kind of our World War II and Korean veterans. And so, as you know, Tom Brokaw called the World War II generation kind of the greatest generation. And then the Korean generation, they're kind of in what we call the silent generation. But most of these veterans were thought of as heroes. And so their experience of the world, they experienced really great economic growth and enhanced opportunities. They were participants in the civil rights movement and change. Socially, they had usually on average one marriage. They were social drinkers, so you actually do see some alcoholism, but very little other substance abuse in those populations. They're actually less likely to have a PTSD or trauma-related diagnosis, but that does not mean they don't have one. It just was that at the time that they served, that a lot of patients did not have that, and later in coming back into the VA system, they're just less likely to have been diagnosed in that way. They also have high rates of frostbite and depression. Those seem to be some of the things, especially the Korean vets, dealt with frostbite much more. And then that's kind of juxtaposed to our Vietnam veterans who are really baby boomers, and they returned amid strife and controversy, and many of them were mistreated. Many of them are suspicious of the system, not all, but many people are, just distrusting. They were raised during a period of great social change, and so they have expectations for things that can be done. They do have PTSD and trauma histories, and really saw some horrible atrocities during their wartime. Also, there was Agent Orange exposure, which has led to a number of related medical diagnoses, and a number of different types of cancer are associated with that. So you will see those types of things that come up with our air trend. Also, what's not on there is that they have a lot of, their social situations a lot different. On average, a lot of them have had 3 marriages. They have multiple different family sources. They have very, very high levels of substance abuse and comorbid mental health issues, not only depression, but a lot of other issues. And so, again, you must consider those things when you're looking across generations and when you're treating older veterans and when you're coming into contact with them and trying to understand kind of even the behavioral problems that they may have or why a certain veteran is belonging. And so with that, wanted to touch again on PTSD and dementia, and that recent research has actually shown that dementia exacerbates PTSD symptoms. So again, that's very important because for a lot of our demented patients who are less able to control their behaviors, some of the symptomatology that we see, some of the behaviors that we see with those veterans can likely be due to their PTSD. Those at risk, those with PTSD are actually at greater risk for developing dementia. So kind of it's a catch-22 in that way. So what do we need to know about PTSD and dementia? We need to know what the triggers are for those PTSD symptoms. So again, when we're considering what the environmental factors are, what things happen, we want to make sure we're considering these things for our PTSD dementia patients, because again, they can have lots of other implications. So TV shows or war-related movies, just violence in general, baths and toileting. If a patient not necessarily had trauma from the wartime, but patients who have had any type of sexual trauma, those patients will have trouble sometimes with bathing and toileting, especially if it has to be done by someone else. The actual sex of their caregiver can be an issue. Smells, sounds, loud noises, constant noises, misinterpretation of speech, that those can be issues. Any apparent threat, and then sometimes physical touch in sensitive areas can also be triggers for these patients. Tucking in sheets and positioning. I had one World War II veteran who would not get along with staff until finally we realized that he wanted his feet untucked. He could not move his feet if they were tucked in the bed because he was so weak, and he couldn't get away. So he had this kind of hypervigilance and this feeling that if he couldn't get away, he couldn't sleep, he wouldn't act correctly, he was denying medications, all of those things simply because his feet were tucked in the bed. Medication can also be an issue. We have, again, talking about prisoners of war. Certain people during those times have actually been exposed to different types of medication and doping when they were prisoners, and so they're actually very, very scared of being given certain types of medications. Again, and pain, because again, they may feel that they're in a facility and don't know what's happening. So what are the implications of that? We need more comprehensive assessment is necessary for especially veterans with trauma histories. and that some of our evidence-based therapies for PTSD are effective for older veterans, but are less effective for those with cognitive impairments. And so those veterans will likely benefit from some of the sensory-based and environmental things that we've talked about. And so that is the end of my presentation. Does anybody have any questions? Oh, okay. I think I have the question about what are traditional EBTs, and EBTs are evidence-based therapies. So for PTSD and trauma, we have research and evidence-based therapies that we implement for those trauma patients with trauma. So different types of exposure therapies and other things. So that's what those are meaning. That, and we also have cognitive behavioral therapy as an EBT. That's often effective, but not necessarily for patients with cognitive issues.
There was a question from Victoria.
Hi, Marilyn. Yes, hi, it's Marilyn. How are y'all? Thanks. The information has been great today. I appreciate it. I'm just over here thinking like I always seem to do outside the box, and I'm wondering when do you decide that you don't need to do brain aerobics, that you begin to start thinking about assessing and quieting that and making that environment a little bit more stable or easy?
So I think that it really depends on your patient and what types of stimulation that they can take. I think that's going to depend on kind of what level that person, where that person is. So again, if somebody is able to follow conversation but can't, isn't a huge participant but really likes to hear music or likes to have the TV on, then that's fine. But sometimes you get patients who, with hearing impairments and they can't necessarily respond, it's just too much stimulation. Again, it's going to be an individual basis. So we know that, for instance, music therapy, again, it likely has a lot to do as well with the dementia process. And that if you have a patient and you play music for them that has kind of historical significance, so stuff they listened to when they were a child or a teenager, again, that can actually be very soothing and familiar as opposed to noises and sounds that are not as familiar. So again, those environmental cues, it's kind of playing a fine line and really trying to understand what's going on with the patient. And then when you talk about kind of cognitive exercising, really that is helpful to maintain processes for people, but what we do know is that we can't bring back functioning, and so if you have a progressive dementia, you're going to just progressively become more and more unable to do those types of things.
Okay, thanks. So along with that, are there guidelines for agencies to follow that would be more conducive? Because some, like I see the Kerrville Transitional Care Initiative here, I guess we'll talk about that later, but is that going to be the way of the future, is that agencies would develop these wander paths and things like that that we don't currently see commonly in long-term care? Because this is a huge number of people that are going to infiltrate these systems in the future.
Exactly. So some of the things that you start to see now are that out in the community, so unfortunately not so much here in the VA, but out in the community, we start to see facilities that actually do have transitional levels of care. So they have retirement homes, assisted living, and then a nursing facility all on the same property. So that patients can actually enter those facilities when they are highly functional and have no real care needs, and then as their needs progress, follow along to that. More of the community-based progressive health nursing homes and locked dementia units, and now there are actually care homes that are specific to dementia care. Those places do actually typically have a wandering path, and actually they don't try to do things like sleep-wake cycle, getting out of whack, and those types of things. In those types of facilities for people who are at the moderate to severe level, they actually don't try to modify those things anymore. They just try to make sure there's a safe environment for people to be able to do those things. Right now, I don't know if there are any mandated functions, but there is really good literature about these practices, but I don't think that there's anything that really just shows and outlines what to do.
Okay, thanks.
Okay, all right, thank you.
Okay, thanks a lot.
Sure, I will send that.